Today we'll talk about extracorporeal therapy in veterinary medicine. For people that know me, they know that I'm really passionate about that. I got exposed to that when I was at UC Davis. Also before that, when I was way younger, I was actually driving my grandmother to dialysis regularly. So that's kind of like my first introduction, but I was not even in vet school at the time. And then after that at UC Davis, I got a little bit more exposed to it, and I really grow like really passionate by it. Today, I want to kind of share a little bit. And I'm sorry if you cannot hear me or if there is any issue. I'm trying to figure out the technology. And also I have my dogs around, so if it's too noisy, I'm sorry about that. So we'll just talk quickly about the history. There's not, a lot of things to talk about it, but I want to kind of introduce the different way we can treat patient and kind of like what we call principle of extracorporeal therapy, that actually the kind of mechanism by which we can treat our patient. One thing that's important is kind of the criteria of the solute that we want to remove, and that will impact like the choice of the therapy that we make. Also, like if we actually can treat with extracorporeal therapy. Talked a little bit about kind of in practice what's going on when we treat a patient, and then kind of focus a little bit on the indication. That I think are like the most interesting part also for us as clinicians. Just so a little bit of history. So the concept of diffusion, osmosis, and semi-permeable membrane, and also like the idea that maybe dialysis could be used in human medicine, it's coming from, it's like what's 1855. So it's kind of a while ago. In 1913, that's when they came with the idea of the artificial kidney. I don't know if I have a pointer with this or if you can see my mouse, but that's the picture on the top. That's kind of what they were calling like the first artificial kidney. In 1920, that's when they did the first experiments on dog, and that's the picture that's in the bottom. You have that table up front where they had the dog. They were using like dog that had a nephrectomy as a model. And then the whole table on the right is actually a bunch of like tube with fluid and semi-permeable membrane. So you see that it was pretty big compared to the dialyzer that we are using right now. And then it's only in 1924 that they treat the first human with hemodialysis. And then they also demonstrate in the survival of human with AKI in 1945 with that type of therapy. In veterinary medicine, the history is way shorter. In 1919, that's when UC Davis creates their program and start treating like client-owned pets, mainly dogs. In 1993, first dialysis treatment on a cat. Dr. Lanston was, I believe, the one that did that treatment, and she's been really a huge proponent of like those therapy. In 1995, they start doing fellowships, and then a second program built by Kathy Langston at AMC was in 1997. Since then, sorry, my cat is trying to jump and make everything move. So in 2014, that's when they start creating, like when the first Hemodialysis Academy took place. And that was really a fundamental change in the way veterinary medicine kind of saw the extracorporeal therapy develop, because before that, it was only like, some specialists that were able to train a couple of other specialists, through fellowship. But then with the Hemodialysis Academy, it became really a worldwide expansion. And if you see on this picture, those are like all the programs that are actually open in the US. And so you see that it's, especially here on the East Coast, we have a lot of programs but also on the West Coast. And if you look, the next here is like the country, and you see that actually Asia, especially Japan, is do a lot of extracorporeal therapy, but you also have a lot of program in Europe, in Australia. So and the Dialysis Academy, it's really like it's a year-long training with 3 lecture a week that kind of give all the background, the theory behind extracorporeal therapy, and kind of like give all the knowledge to be able to to treat a patient with the machine. To give you an example, my urologist actually told me last week that he's part of a program that's trying to build a hospital in Guatemala to have like dialysis for like humans. So they basically have like a bunch of machines. They can only get those patients 2 or 3 hours on the machine. So there was probably like 80 people waiting every day to be treated. And on the other hand, with veterinary medicine, like we just, we have all those programs developing, while in human medicine, we still have like some improvement to make in that area. All right, so talking about the principle of extracorporeal therapy. So the main kind of like when we talk about extracorporeal therapy is just like we have a treatment of a patient, like treatment of the blood outside of the body. And most of the time we try to remove something like an unwanted solute. We will see that we can actually also add things in the blood, but the main goal usually is to remove something from the blood that we are not able to get rid of in another way. So extracorporeal therapy means that there is an extracorporeal circuit. So it means that the blood is coming out of your patient, go through a circuit that will kind of talk a little bit about it, and get a specific treatment. Either is dialysis or it's adsorption. That can be also like plasma transfer, so filtration that will remove the plasma or some other component, and then that will being giving back to the patient. There is five main way or like mechanism that are used in extracorporeal therapy. And I know a lot of people are talking about dialysis, but dialysis is actually only a little part of it. And that's why now we really tend to switch to extracorporeal therapy or ECT. And even like, in lectures, and now they really kind of switch that name, because we have like more and more therapy that are like developed and that are not just dialysis. So when we're talking about dialysis or hemodialysis, it is only a diffusive therapy, and we will go over like the detail of that. Ultrafiltration is mainly removing fluid. We'll use for cardio patient and for like our AKI patient that are overhydrated. Hemofiltration is using the drag of the fluid that we are removing for also like pull like some solute that are like middle-sized molecule, and that's the convective therapy. Hemoperfusion is everything that's going through filter when there is any kind of absorption, so something that will bind the molecule directly on that filter. That's actually not really a filter anymore, it's just a column. And then apheresis, that's kind of like, it's kind of like a technique that it's got something that's really developing a lot right now. And there is a lot of opportunity of therapy with that, is the principle of separating the plasma and the cells and remove one or the other one. So when we talk about diffusion, it's the principle of the bag of tea that you put in a hot cup. When you have like those molecule that kind of diffuse out of your bag of tea. So it is really working as it's against a gradient. So you have a high gradient on one side, then you have a semi-permeable membrane and a lower gradient on the other side. So Rose, can you tell me if I have a mouse that I can use or a pointer that I can use on the slide?
We can actually see your mouse.
Like, can you see it here?
Yep.
Oh, okay, great. Thank you. So if you see, for example, here in the first container, you have like a solute here on the left that's 10% concentrated, it's 20% concentrated.
Sorry, Dr. Fosset. Just kidding. We don't see it anymore.
Here?
Yes. Oh, yes, there
All
it
right,
is.
that's the other screen. That would be unknown for me because okay, I will figure out. Here, so in the first one, you have like different of concentration. So the solute here is 10%, 20% here, and that's a semi-permeable membrane. So meaning that when you have like more solute on this side, they will just cross and go, and then you have an equilibration here. That's true for the small size molecules, so between 500 and 1,000 Dalton. So they will just like those small molecules will just have like a higher tendency to hit the membranes and go through the ports and then kind of equilibrate on both sides of the membrane. So it means that when we use this for our treatment, we will only be able to do that for small molecules. So when we do hemodialysis, of course, we have the blood on one side, and then you have the dialysate on this side. So if you have a patient that's uremic, so an AKI patient, it's mainly like urea, creatinine that will be, that will diffuse from the blood to the dialysate and will be removed. If the patient is hyperkaliemic, same thing, the potassium can also diffuse. On the other hand, usually the bicarb is low in the blood for those patients in AKI, and that can actually be provided by the dialysate. So that's really the whole, when we talk about dialysis, this is the main thing, is equilibration through a semi-permeable membrane and through diffusion. Ultrafiltration. So here we're talking about movement of water through the membrane, and that's allowed by the transmembrane pressure. So meaning that on one side of the membrane, on one side of the membrane, you will have, in this case, it's the blood here on the left, the filtrate is here on the right. So you will have a higher pressure in the blood, a lower pressure in the filtrate. And so on both sides of that membrane here, that's in the middle, and that will drag the water out. So that would be important to, for the patient that, again, overhydrated if they are an acute kidney injury, or also a cardio patient that are like in a way overhydrated too, you will be able to remove the fluid. So when we talk about, we have the ultrafiltration, and I know all those names are confusing, hemofiltration, hemoperfusion, I sometimes have to think about it too. But so ultrafiltration will remove the fluid. And so hemofiltration, we actually use the movement of water through the membrane. So here it's illustrated, you have the positive pressure on the blood, the negative pressure on the filtrate, the water is moving. But because of this movement of water, we're able to, to pull some medium-sized molecule through the membrane, things that we are not able to do just by diffusion. So in those that are like middle-sized molecule, 1,000 to 10,000 Dalton. And so that's the big benefits of having those kind of therapy that are pulling fluid through the membrane, because first of all, we are removing fluid, but we are also able to get some molecules that have a higher molecular weight. Hemoperfusion. So typically, like the way we can imagine that is, we have those patients with intoxication, we give them charcoal by mouth, and the goal is to kind of bind all the toxin or crap that they ate. And basically, the absorption with hemoperfusion is the same principle, but instead of having the charcoal directly in the patient and having to fight with them, we can directly have the blood going through the charcoal and binding, for example, if it's like a ibuprofen or any drug intoxication, we can directly have the drugs removed in the cartridge by having the blood going through. That technology is mainly used for intoxication, but now we have like some, for example, the vet rescue can be used also for intoxication, but also work for patient with thirst and sepsis, and we'll talk about it a bit later, but the same principle, it will bind the cytokine and also the endotoxin. So everything that's absorption, it's something that would be bind in the column in which the blood is going through. Apheresis, and that's really the most, I mean, I don't know, it's not the most interesting one, but that's the aspect of ECT that just really developing a lot right now, and there is a lot of indication and new treatment that we can provide to our patients. So apheresis is basically you are separate the blood between plasma and the cells. You can either remove the plasma and give new plasma to the patient. So that's therapeutic plasma exchange. That can be done with the Prismax. With the Prismax is a filtration system. And then with the Spectra and the Amicus, it's a centrifugation that will separate the cells from the plasma. You can also separate specifically some type of cells, and that's only the Spectra and the Amicus that can do that, and kind of isolate the type of cells that you want to remove. We'll talk about that later, but the main difference is like you have the apheresis, so the plasmapheresis, so the therapeutic plasma exchange, we are separating the plasma and removing it, and cytopheresis, we are separating the cells and removing some of them. And we can be really specific with the type of cells we are removing. And that's really the beauty of those therapies. All right, so when we talk about solute and something that we want to remove from the body, there is three main aspects that we need to have in mind. Is first the volume of distribution, the percentage of protein binding, and the molecular weight. And those are the criteria that will tell you, yes, I can, if you call me and say like, this dog ate, this drug, based on those information, I will be able to tell you like, okay, well, we can try an extracorporeal therapy technique, and then which one we will try. So the volume of distribution, it's important because we are treating only the blood. When we are doing a treatment to a patient, like we can extend the treatment. Instead of doing 6 hours, we could do, like 10, 12 hours. And that will allow to, for the drugs, for example, that we remove from the blood, if some are in the tissue, to kind of move back in the blood, and then we can remove some more. But fundamentally, if you have a high volume of distribution, meaning that your drug is distribute in fat, muscle, and bone, there is not much left in the vessel, in the blood. And that's the main location where we will be able to remove it. So a low volume of distribution is good. It's something that we will be able to remove more easily with extracorporeal therapy. A high volume of distribution, it is more difficult. We can still remove those molecules, if the volume of distribution is not too high, but sometimes that will require either longer treatment or to do like treating for 6 hours, wait 12, 24 hours, and then retreat to have the time to have a shift of molecule. But really high volume of distribution, it can sometimes be really challenging, and sometimes we are not able to remove those solutes. Protein binding, it's important because if you have, and most of the time it's albumin that will bind a lot of drugs and molecules. If your the solute that you want to remove is highly bound to albumin or other protein, when, sorry, I was on the wrong screen. So here, like you see, if you have like molecules that are highly bound to the protein or mainly albumin, when the blood is going to be in contact with the semi-permeable membrane in the dialyzer, those molecules that are attached to albumin will not easily cross and go in the dialysate. It will have a tendency to stay in the blood. So it means that just dialysis itself will not be really efficient to remove those molecules. So we will have to think about other ways to be able to remove those molecules, and partially is either doing absorption. Some filter will be able to like bind those molecules even if they are on proteins. They will have a higher affinity and be able to remove them. Or we can do plasma transfer, when you will basically remove the protein with the molecule and then replace with another type of plasma. And please let me know if there is any question. I don't know if I can see the chat. So the third, so after the volume of distribution, the protein binding is the molecular weight. So the size of the solute, and I kind of allude to that when I was talking about diffusion, convection, is like for pure diffusion, you would have only like small molecule. Again, I'm sorry, I'm on the wrong screen. So if you have like small molecular weight molecule here, you will be able to remove those easily with diffusion. So just with dialysis, and that includes, you know, like your electrolytes, urea, creatinine, phosphate. I put it here: diffusion, high flux, and low flux. It's just some dialyzers have different properties, and are allowed to remove like higher molecular weight molecule, like the glucose and some other molecule. If you have like a molecule that's middle, like has a middle molecular weight, those molecules, we have to think about doing more than just diffusion. And so we may have to start thinking about convective therapy. And that can be done by not just, you know, doing the diffusion, but also removing fluid and replace that fluid. And so we can improve the removal of those middle-sized molecules, sorry. And then when you have like really high molecular weight molecule, and that include albumin, so and everything that will bind on the albumin, then you need to think about doing TPE. So a way to kind of like summarize here, again, if it's a low molecular weight, that's great. That's something we will be able to readily remove with extracorporeal therapy. If the volume of distribution is really high, it would be challenging and may not be possible. But then if you kind of combine after that the molecular weight of the molecule and how much it's bind to the protein, it kind of help you decide like, okay, well, if I have a molecule that's, let's say, it's like 7,000 Dalton, and it's like 50% binding to the protein, so you probably, oh, I'm sorry. So you will probably be like about this zone. So you see that dialysis should probably work, but you may not be really efficient. So you may want to maybe use some convective therapy. But like if you end up having like a molecule that you know is like 85% bound to the protein, you know that you will not be able to remove them with just dialysis. You will have to think about hemoperfusion or TPE. So it's kind of like how we decide based on the molecule that we try to remove. And, you know, it's really important also for the intoxication, because for renal disease, we kind of know like that dialysis is working. If we have like a liver patient, liver failure, like we know that we need to kind of hit a little bit higher. We know the characteristic for those patients usually, but like if it's an intoxication, those data are really important to see if we can remove the molecule or the solute, and then how we can do that. So just a few words on, the practicality of extracorporeal therapy. So, like I talked before, like we have a patient, we need to have a catheter that usually are like placed in the heart, and I will go over that a little bit later. And then you have like a circuit outside of the patient. So you have the blood going on one side, you have a pump here that will pull the blood from the catheter, then push the blood towards the dialyzer. So in this case, that would be like a classical dialyzer with, the blood going in one direction, and then the dialysate here that's going in the other direction, and then the exchange in the middle. And then that blood is going in air chamber, and then going back to the patient. So that's kind of like the most simplified view of it. Realistically, it looks a little bit more like this. And you have a lot of pods that are like pressure sensors. This is from an Optia, so it's for like a plasma transfer. But different circuits will have like different shape, and honestly, sometimes it's just it is really difficult. Like it takes time to kind of get used of each system and see like they all have the same thing. They all have sensor. They all have a pump that will, pull the blood from the patient and push through the circuit. They all have like a air chamber to catch the bubbles before it's going back to the patient. It's just that will be designed a little bit differently. The catheter, and that's a big part of the treatment. It's usually a large lumen catheter because especially for intermittent hemodialysis, we need like really high flow of blood. There is different material. Polyurethane is really common. Silicone is a little bit, it's definitely silicone better. It's more comfortable for the patient and well tolerated. It's placed with modified cylinder technique, exactly like the other jerk catheter that we place in ICU. Sorry, there is different type of catheter in the way where some are used temporarily, and then the other one I usually use long-term, and they are cuffed. We'll show some picture. To be honest, like in veterinary medicine, like we use temporary catheter, and some are staying in for months, and it's working really well. And then the really important thing is it's really an aseptic technique, and you will see that's done in the OR. We are fully protected, and even after that, every time we manipulate the catheter, we are masked. We have like a drape around the catheter. Everything is scrubbed every time we are opening it. And the reason, because we need to place those catheter, and it's really the only way we can treat patient sparing the jugular vein, it's extremely important. As well here, I mean, at Northstar, the hospital, when we have those patients coming in, be conscious that, if it's a patient that may need extracorporeal therapy, we really need to try to preserve the veins, the jugular veins. But also when patients are referred to us, try like for the RDVMs, like if possible, to get the blood from other vessel, or even if you have a patient that's maybe an AKI patient, or like, a CKD patient, a chronic kidney failure patient, that the owners may consider more maybe long-term dialysis, to really start thinking about like not using the jug to get blood sample. Like, so sparing those jugular is really important for the ECT therapy. And those are example of catheter. So like this is typical like acute catheter. The big difference you will see in the bottom one, you have like here, it's a Dacron cuff. That will allow to have kind of a more stable, it will be more stably attached to the patient. That may make sense here. So that's an acute catheter. You see that the track here in under the skin is not really long, so probably entering the vein here. In this case, you have this old track, the Dacron cuff is here, and it's entering the vein here. So this needs to be like surgically placed. The Dacron cuff will cause like a fibrosis in the skin, and that catheter will hold for really long period of time. So those are like the main difference between those catheters. And then here to just illustrate that we have two really large lumen with the extremity of the port can be either like separate like that. Sometimes they will end at the same spot. But those are the typical shape of our ECT catheter. Ideal placement for those catheter is in the right atrium. Also, the caudal vena cava can work pretty well. So the picture here on the bottom, it's just in the right atrium. So usually you get a really good flow there. In the vena cava here, you get a decent flow. You just have to reverse the catheter. I don't find my word. Like you just have like the flow would be just opposite. That's what you have usually. So when you connect the patient to the machine, you just have to invert the port of the dialysis catheter. But sometimes you can go in places that are not really conducive, that will not give you a really good flow. So here in the bottom, the catheter went in the azygos vein. And actually, the patient we have right now at the hospital, I think that when we check the placement of the NG tube, it looks like the catheter is probably there right now. So we'll have to figure out tomorrow what to do. And then sometimes the catheter is literally not in the vessel. And so that's like a paravenous placement. It's not really working for therapy. Just to work on the hemodialyzer. So, we saw on the previous picture with the circuit, you have like one side where the blood is coming in. So when you have like, for example, the Phoenix machine, this is the way it's set up. So the blood is falling, coming from the top and then going down and then going back to the patient. If you have the chance to see when we'll use the Phoenix, like the first pass of the blood in the dialyzer is just beautiful. You can literally like see the blood like going through, and it is really cool to watch. And the dialysate usually is going in the opposite direction. So if your blood is going down, your dialysate is going up. And if you cut the dialyzer like that, and there is another picture after, but if you look from the top, like those, it's like a bunch of little straw that are in the filter with the blood traveling inside of the straw, and around the straw is a dialysate. And those straw, the next picture, those straw here, that layer around it is the semi-membrane, permeable membrane. And so you see this is like a cut in a dialyzer when you see like all those little straw. And that's just another illustration. This is just illustrated again, the difference of flow. So it is really important to have the blood going in one direction and dialysate in the different direction just for the exchange. I don't want to talk too much about like the more like technicality of the treatment, and but that's something, if some people are interested, we can definitely go more in detail. But this is kind of illustrating the different flow and exchange. One of the big thing also for a treatment is that because we have blood going outside of the patient for sometimes like up to 2 or 3 minutes, usually we try to stay under that. We need to anticoagulate those patients. So there is 2 options. The first one that's the most commonly used is that we give heparin to the patient himself. So the whole body and the circuit is anticoagulated, so systemic anticoagulation. And then something else that we can use is the regional citrate. And that point, in that case, it is just the circuit itself that's anticoagulated, meaning that when the blood of the patient is getting in the circuit, some citrate is added, and then all that blood that's then traveled through the circuit is anticoagulated, and then we give calcium at the end to neutralize the citrate. It is a little bit more difficult to use because as soon as you change the blood flow, you need to start like playing with all the rate of the calcium and the citrate. So it is a little bit more work, but it is pretty efficient. And for a patient that could not tolerate to get any heparin, that's definitely a good option. In some cases, we also don't use anticoagulant. It's rare, but in some cases we have to when we have a patient that's hypocoagulable. Usually we use to monitor the coagulation, we use the ACT, and that's kind of the range, like 160 to 200 is about like the range that we want for the ECT. And then one other thing that's important is avoid any invasive procedure, and that includes doing like a cystocentesis, placing new IV access, or like try to get bloods like, you know, probably 12 hours before the procedure, and especially after, because those patients are anticoagulated at risk of bleeding. And the main reason why we need to anticoagulating those patients is this. So like here, those are like the pressure chamber on the Phoenix machine, and you see that there is like huge clot here. So this is the arterial side. So the blood is coming through here in that chamber, and then, you know, then we have the pump, and this is the venous side before it's going back to the patient. And you see there is like those huge clot here. Those are the header of the dialyzer, so the top of the dialyzer, and you have like those like huge clot here. This is the crit line. It's a part that we use for monitoring. There's also a huge clot here. When you see those, and that's something we need to inspect after each treatment, it means also that your dialyzer is full of clot. And that has a huge impact, because it means that your treatment will not be efficient. So that can drastically increase the time of treatment of your patient. Another place you will find those clots, it's on the in the catheter itself. So you see here, you have like clots inside the catheter. Here too, this is like a sheet of fibrin. All this will prevent to reach the flow that you need to be able to treat the patient. And so that's a huge problem. And that's why we also lock those catheters with heparin usually. Just a few words on the dialysate. So if you use, for example, the Prismax or the Prismaflex, it just comes with back. So you don't have a lot of flexibility with what you are doing with your dialysate. With the Phoenix machine, that's, you know, it's here on the picture, you have like a source of purified water. So we have our water, we have our water unit, and that give us like purified water. Then you have acid concentrate, and then you have bicarb. That will allow you to basically decide exactly what you want for your patient. You can decide of the amount of bicarb, you can decide of the amount of sodium, and you can also add some different things, like you can add phosphorus. So if you have like a CKD patient that's on chronic dialysis, usually the phosphorus is high, but if you dialyze that patient every 2 or 3 days, your phosphorus will just be, you know, decrease drastically and start being low. And so we can add that in the dialysate. And funny fact is that we actually use enema for that, the fleet enema, because they have like a high concentration of phosphorus. And so we add them to the acid concentrate, depending of the amount of phosphorus we want. We have like some rules, and then that's how we actually add phosphorus. And the other thing is that when we have an ethylene glycol intoxication, we can add ethanol in the acid concentrate, and that would allow us to also dialyze the patient and treat the intoxication. All right, so I think this part is probably a little bit, this part is interesting, and I think we actually don't know where is the limitation about the indication for extracorporeal therapy, because we're still discovering like new way to treat our patient with those therapies. So the first thing is that, yes, we can treat kidneys, but it is not just kidneys. And I hope that by now you guys figured that out. And there is the part that's like acute renal failure and chronic. There is the liver failure that we can also treat or help. Heart failure with removing fluid, sepsis by controlling the inflammatory response. A lot of immune-mediated disease. For us, like I think what we are treating the most is ITP and IMAJ. Myasthenia gravis, actually, it's really impressive when you have a dog that's down, not able to walk, when either it's like an acute diagnose, or it's like a really bad relapse. Those dogs get in the dialysis room or the ECT room, not able to walk, like weak, and they literally walk back to their cage after like, I don't know, 4-6 hours, no, probably like 4 or 5 hours treatment. So it is really impressive of how well it's working. You have some skin immune-mediated disease with snake envenomation, also like when you have like secondary inflammatory response. And then there is some indication also in oncology and intoxication. So replacement renal therapy, renal replacement therapy. So one thing that we need to understand is that extracorporeal therapy, even if they will help our patient, are not always the final treatment, meaning that it is mainly a support for the patient to leave the time for the kidney to recover. That's the same principle with the liver disease, is that we just support the body, we support the patient, so the kidney or other organs are able to recover and regain some function. You have, for the acute kidney injury, the main indication are with severe azotemia, but hyperkalemia, it's a big thing. And the really cool thing is when you have a patient that's extremely hyperkalemic, that has some arrhythmia, as soon as you place the dialysis catheter, that you start the treatment, you can actually see that ECG totally reverse and become totally normal, because the blood that's going back to the heart is actually potassium free, or at least has a normal concentration of potassium. Severe metabolic acidosis, oligonuria, and overhydration, those are kind of the criteria when you will need to think about extracorporeal therapy for your patient. And when, of course, like those are not responsive to medical management, and we're thinking mostly about furosemide and mannitol. One of the big thing is that the fluid overload, the overhydration, that's what kills patient with AKI, not the AKI itself. It will cause high blood pressure, there is edema, the discomfort, and this is really the reason why those patients are dying, because we keep giving them fluid they cannot get rid of. And also, like the edema, it's really important because the kidney also get edematous, but he's stuck in a capsule and he cannot expand. And so when you start treating those patients, you will see that a patient that will be totally anuric, we will start the first treatment. And sometimes the main thing we can do is do ultrafiltration and try to remove as much fluid as possible from the patient, because we need to be kind of careful with severely azotemic patients. We cannot treat them too fast. And those patients, when they have a UCAT, you can sometimes see that by the end of the treatment, you can actually, they start producing urine. And that's really just the edema. So it really illustrates that you can actually even make a patient worse by giving too much fluid. So it's really, really important, if you can objectively say your patient is not producing urine or not enough, you need to stop the fluid if he's, hydrated. And this is, kind of typical. A patient that coming for a treatment overhydrated is probably like over 10% overhydrated. And then they can sometimes finish the treatment looking like that, like an actual lab and not like a blob there. You can also treat chronic patient, or, it's like the picture here is Callie. So that's actually our first patient that we start treating last week. So she was treated as an acute patient. And now we are kind of in the phase when we may be in the subacute phase, meaning that, sometimes we usually say like 3 treatment, that's what they need to kind of like feel better, be able for us to like decrease the azotemia. And then from there, we can see like, okay, are the kidney able to recover? Are they starting to do some kind of work, or they just like totally shut down? Sometimes they will need like a couple of weeks from with dialysis as a support, because the kidney can still sometimes recover after like a couple of weeks, depending what's the underlying disease and if there is any underlying chronic kidney disease. One of the best example is Dr. Segev that usually mentioned that dog. Was a large, I think that was a Irish Wolfhound, something like that. He's in Israel. He's working there, and that dog came in. It was an acute AKI. He was probably 2 year old, and the dog was totally anuric, and he stayed anuric for probably more than a month, maybe a month and a half, I believe, and then slowly stopped producing urine. And so all that time he was on dialysis. And then after 2 months, I think he was off dialysis, producing urine with probably almost normal kidney value. And that's a good example that the kidney can actually recover more than we thought before. Like we always know, like, oh, well, the liver, we know liver can recover, but the kidney, when they are done, they are done. And that's a good example. If it's a young dog, you actually can have some recovery of kidney function. And so that acute subacute phase is kind of like that phase when we are treating for an extra couple of weeks and kind of see if we have sign of improvement. For example, Kali is producing urine, and she was anuric. At some point, it looks like she stopped producing again enough, and then now she's back on track. So, but it's a sign of improvement. It means that, at least she's able to produce urine. So there is some hope that she may be off dialysis, but right now she's still dependent, and she will have another treatment tomorrow, hopefully the last one. But if we see that she continue to improve slowly, or like that she can be managed with subcu fluid for a while, then that will be fine. And then when we talk about chronic patients that are like dialysis dependent, it's not that common in veterinary medicine. There was a few cases when I was at UC Davis. BB was one dog that was treated for like more than a year, I think a year and a half. And there was a few other patients. In the subacute patient, you also have cats that are waiting for kidney transplant. So those are also part of the subacute. But it's a commitment, it's expensive. And at the end, that's also the quality of life of the patient. Some patient will do great on dialysis. Between the treatment, will still have a good quality of life. Some other patient will not tolerate the treatment, will be overhydrated pretty quickly after less than 24 hours. And so at that point, that this is not fair for the patient. So the quality of life of the patient is always the priority. And for Kali, we can tell, like, after a treatment, she's just like wagging her tail and she's all happy and try to bolt from a cage. And then you have the overnight nurse complaining because she's not behaving. But that's a sign that, she started reading well the treatment, and then after the treatment, she's feeling great. So that's a positive sign. Any questions so far? That everybody sleeps already? All right. So when we talking about renal replacement therapy, we can have intermittent hemodialysis, the IHD, continuous renal replacement therapy, and then peritoneal dialysis. This is the only time I will mention that. I don't think that some university are still, and some hospitals are still using peritoneal dialysis. I think it's definitely a good option when there is no extracorporeal therapy possible. But yeah, I don't think that, I think it will slowly fade out. So when we talk about intermittent hemodialysis, this is typically the Phoenix machine. It's high efficiency treatment. It's usually, if you know people that are on dialysis, this is the kind of treatment they get when they go 2 to 3 times a week to the hospital. That's the one I was mentioning, that you need to have a RO water unit. And then, you have a lot of maintenance. But the benefits also is that you have a lot of flexibility. So you can choose your potassium, you can choose your sodium. There is a lot of flexibility, and that's kind of the nice things with those machines, that you can have like a treatment that's more tailored to your patient. The second way to treat is continuous renal replacement therapy, and that's typically that you have the Prismaflex, that's the old version, and now the Prismax. We have the Prismax here at the hospital. Those machines are more, they are less efficient, and so the goal is to have like a longer treatment. So basically, if you go in human hospital, you go in ICU, and people are like plugged to those machines for 20 or 24 hours at a time. So the treatment is really slow, especially when, patients are unstable, it's better. And then they will treat them really slowly. It's also, they have to replace the bags, because, you see here those bags hanging. You don't have the luxury to choose like your sodium or your potassium, or like, well, how do you want to treat? You just have to choose from the bags that you have. Sometimes you can modify them a little bit, but that's what you are using. And this is really more like for more continuous therapy. Now we are using that for intermittent therapy. If you have like a ethylene glycol intoxication, this is not efficient enough to treat that patient. Callie, she's only 6.5 kicks, I think 6.3 now. She's really small for that machine, but on the plus side, we are able to do like a fairly efficient treatment for her. Like if we had like a big lab, 40 kicks, it may be a little bit more difficult, and there is a way to kind of work around that. And then that's the last kid in the neighborhood, or kid in the block. I don't know what's the expression, so just scrap that from the recording. But that's the CarpeDiem is a new machine. It's cardiorenal pediatric dialysis emergency machine. So one of the big problem we have with extracorporeal therapy is the size of a patient. A lot of them will not really tolerate like the size of the blood circuit that we have to pull out of their body, like the amount of blood we pull out of their body to be able to do the therapy. And we sometimes have to prime them with blood or other type of fluid. The CarpeDiem is a pediatric machine. So you see that the patient weight is between 2.5 to 10 kgs. This is a big number of our patient that we would like to treat, and it's definitely include like all the cats that we would like to treat. So I think the blood circuit is like 30 or 40 ml. It is kind of like almost nothing. It's a continuous therapy, so a little bit like the Prismax and the Prismaflex. But again, there is a way to kind of play around. You can add convective therapy to make it a little bit more efficient. So it's a machine that definitely, like, we are looking into maybe getting it for the hospital. That's something that has like one of my mentors that have the machine, like, use this for every cat that he's treating. I don't think he's using any other machine for his cats anymore. It is how safe and easy it is to use on those patients. And so, we can do fluid overload patients, so small cardio patient, we could help them, cats, and then all the AKI patient. And then the TPEs, like therapeutic plasma exchange, it's not really going with the kit, but there is a way to kind of trick the machine and change the filter, and then also doing therapeutic plasma exchange. So, sorry, I'm feeling. Yeah, so we talked about kidney disease. So just a word about toxicosis and drug overdose. The thing that really we want to know to see if extracorporeal therapy actually it's needed or an option for those patients. I mentioned the volume of distribution, the molecular weight, the protein binding. But then something to do on also like on admission is like confirm like how much did the patient ingested? Is it like a sure injection or like is like, well, maybe one or two tablet, or like they literally saw him like eat a whole bottle of Rimadyl and it's a small dog. Is it a life-threatening intoxication? You know, like marijuana, for example, it's most of the time not life-threatening. We'll probably not stop treating those patients with extracorporeal therapy. Usually we monitor them, give them fluid, and they're doing okay. If it's a small dog that ate carprofen, we know that the risk of kidney injury, irreversible kidney injury, or even like sometimes the GI perforation can be really severe. And so if the dose is high enough, then okay, well, that maybe there is something we have to do. If it's a long half-life also, like if it's a drug that's eliminated of the body in 6 hours, we'll probably even don't have the time to treat this patient. If there is no antidote, and then if there is no way to decontaminate this patient. So those are kind of like the criteria that you have to keep in mind when you see one of those patients to kind of see if extracorporeal therapy can be an option. And it's important to refer early. I saw during my residency, we didn't have like extracorporeal therapy, but then one time we asked me about that dog that ingests like Rimadyl, like a high dose of Rimadyl, like 5 days before, and then was now starting to be azotemic. I'm like, that dog came like 2 hours after ingesting the Rimadyl. They knew the dose. I was like, well, sure, like he's a little bit azotemic now. He don't need really dialysis for that. But if he came, if he was treated right away, we would have removed the drugs from his body, and like in 5 hours, either TPE or like absorption, and this dog would be totally fine. I unfortunately had to euthanize a golden that was 1 year old, and I ingest a lot of NSAID, and it was heartbreaking to see that that dog had to go to be euthanized while, the time he spent in the hospital actually to treat that intoxication, and would probably have matched the price of treating this dog on admission, get rid of all the carprofen, and the dog was still alive. So it makes a really big difference to really think about extracorporeal therapy early when you see those cases. Like if it's really like, oh, well, we think that he ate a tablet, we are not really sure. It's like a huge lab, or just like whatever. Like just see like what side effect you can have, but most likely you'll be fine. But like if it's a small dog, he ate a huge dose and it's really confirmed, those are cases when it's just like you really have to consider extracorporeal therapy. Again, and that's kind of like the same kind of type of graph, but like how we treat those patients after we decide like, okay, well, we probably need to try to remove that medication or that drug that the patient ingested. So we just look volume distribution, protein binding, molecular weight, and again, it will help us to decide like what type of therapy we will use to treat this patient. And to be fair, we like here are like some example of medication that we have experience with. NSAID is really common, ethylene glycol. And many times mushroom, the prognosis is not really great. But to be fair, there's a lot of medication that we don't know if we will be able to remove them or not. And the experience have shown that some drugs that were just like, we don't know if that would be removed with extracorporeal therapy. And then when they treat those patients and then they take samples pre and post, they realize that they can actually remove those drugs. One of a good kind of guide or help to figure that out, like based on the medication, you have those dialysis of drug. There is a book. It's also an app, and you can basically enter, like if your dog eats, I don't know, an antibiotics like doxycycline or whatever other medication, lithium or Adderall or stuff like that, you can actually enter the name of the drug and it will tell you, is it something that can remove by extracorporeal therapy? and then which one actually of the extracorporeal therapy. So that's really helpful when it's not like a typical drugs and then there is a huge amount of drug ingested. Also, a lot of time we have patients coming in, and Pumpkin that's in the hospital right now, that PD came in and she had like, she was like tremoring, she had like seizure. It looks like that was an intoxication. We didn't have a really good history. She did well after 24 hours, but sometimes you have those patients that end up on the vent. And realistically, a lot of time we don't know what the intoxication is. And so the consideration, is that, okay, well, if it's bad enough that the patient is on the vent, maybe we can consider doing extracorporeal therapy, and you can do, dialysis and also adding a charcoal to remove the drugs. All right, so I'm seeing that it is already late. Rose, can you tell me like if I can go over a little bit?
Yeah, that's fine. And if anybody has to jump off, that's fine. We'll be emailing your CE certificates for those on Zoom.
Yeah, I will try to go a bit faster. I'm sorry, like when I start talking about dialysis, I just don't stop. I will try to go a bit faster. I may skip a few things, and then if anyone has any question, I'm happy to answer later. Immune-mediated disease. So again, that's one of the type of disease that we really have a good experience with at this point, especially with IMAJ. Kind of like the guideline to know when to start treating is that if you have to transfuse the dog twice in the first 12 or 24 hours, most likely it will be fair to start them on extracorporeal therapy. One of the big benefits is clinically they will look better. There is less risk of complication. You can decrease the amount of drugs that they will need to be stabilized. And then there is UC Davis, I think it will be published soon, but their studies show that there is an 80% survival with TPE for those patients compared to like 54% without TPE. And I think more than the survival rate is also like how the patient look. I don't know how many times the owners after a couple of days with an IMAJ said like, oh, my dog is suffering. They're like yellow, they're feeling like crap. Those dogs, you treat them once and it's just like, oh, I am ready to go home. So they really feel better. And I think that's a big thing. You get less complication because you are able to remove all the bilirubin. There is less risk of through clot. We're usually talking about like 3 to 4 treatment for those patients. It's usually treatment day 1, day 2, sometimes day 3 if they are really sick, and then a couple days after. So it's either 1, 2, and 4, or like 1, 2, 3, and 5. That's kind of the typical, and we don't really know why the third treatment is needed. But even in human medicine, they show that even humans, like if they do only 2 treatment, the patient is doing great, the risk of relapse is actually higher. And we see the same thing with veterinary patient. Some immune-mediated disease, neuropathy, like myasthenia gravis, like I mentioned that, but there is others. Guillain-Barré syndrome, that's in human medicine. It's also a disease that there is antibody that will bind on the receptor. So all those diseases actually responding well to extracorporeal therapy because we're able to get rid of those antibodies, mainly during TPE. Other disease, heart failure, I mentioned that, removing the fluid. So I would say that for us, like if we have a patient, that is in non-heart failure, that's just like doing really poorly and that we have to intubate, often we say like, well, if you have to intubate, bad prognosis, but those patients can be intubated and actually put on a machine and we can drain them and probably like be extubated by the end of the day. So if it's a patient that's, early in the heart disease that, we still have some medical option, let's say that the owners were didn't give the drugs for like a couple of days for like any random reason, not just because they cannot give it, because long term that will be a problem. That will be an option. Also, patients that have like an end-stage disease with diuretic resistance, in human medicine, they have shown that treating with extracorporeal therapy, I mean, with infiltration can help resensitize the patient to the diuretic, and then they can remove, decrease the dosage of the diuretic. Liver disease, I will skip that. It's basically the same principle than kidney disease. It's just give more time to the patient to recover. You're able to remove, the bilirubin. They will feel better. This is the way it's done. That's the old way to do it. In human medicine, they had the Morse and Proteins Prometheus platform that was doing like an albumin dialysate, a double dialysis. So there is the blood of the patient. Here the dialysate has albumin. So it will, bind the bilirubin, and then that fluid, it will be redialyzed on the other side and then go into filter. So it's a more complicated way to do it. You had like those machines that they're actually not doing anymore. It was like a double dialysis treatment, but we can actually sorry, something is not coming. There we go. We can actually achieve that by therapeutic plasma exchange and hemoperfusion and really help those patients, feel better. Other indication, that's the part that's really interesting for us in critical care, is for patients that have like a systemic inflammatory response syndrome. So it include like sepsis, heat stroke, some leptospirosis patient, pancreatitis. Those are potentially patients that have a really high inflammatory response. And we know that with some of the cartridges like Vet Rescue, we are able to bind endotoxins and also downregulate the inflammation. So those are like, in human medicine, there is really, really strong literature. So patients that are like in septic shock with vasopressor, when they start them on those therapies, so they start like filtering the blood to a Vet Rescue. It's that has another name in veterinary medicine, in Cytosorb, in human medicine, they can actually like discontinue the vasopressor fairly quickly after starting the therapy, because that helped the stabilization of the patient. So I think there is really good opportunity for us in veterinary medicine to use that. They start having some publication coming out, but that's a really exciting area thing to investigate. Oncology, it's mainly cytopheresis, meaning that they will just selectively remove some cells. There is some treatment, like this is like an example of like CAR T cell therapy, when they get the T cell lymphocyte from the patient, and then they do some type of treatment. With the CAR therapy, they add usually some gene, and then they multiply those cells and give it back to the patient. The goal with, either the adoptive cell therapy or CAR cell therapy is like to modify the cells that we are taking from the patient, and that modification will make make those cells an active agent destroying the cancer cells of the patient. So there is like some trial that are going on right now for lymphoma, osteosarcoma. Those are things that are still in development, but there is opportunity there to try to improve treatment of a patient. The Journal of Clinical Affairs is publishing, they just published the new version here. It's a guideline, and there's a lot of disease in it. I just put a few, but you can see like the third one here is myasthenia gravis. And so basically what they do is that they look into those disease and the literature and say like, well, here category 1 means that yes, the having like treating with TP as a first line of treatment is recommended based on the literature. But 1B means that, you know, that's like decent evidence. If you have like a grade 3, is that may help you. I think it's going down to grade 5 when they say like it's contraindicated for those type of disease. And then they also, again, give you like the kind of literature, if it's like a really robust study or it's just like a few case report, you know, to kind of base your judgment. A lot of those diseases actually are also present in animals. And so it is something to, it's a good resource for us to look into to see like for example, I put here like the DCM. In human medicine, it's category 2. So they're actually treating with TP some of those patients with fairly good results. Well, actually, the TP is 3. That's an interesting resource for people that are interested. Extracorporeal photopheresis, it's kind of like the same principle than the CAR therapy. There is a treatment, something is administered for the blood, and then there is like UV light, and then it's given back to the patient. The difference here is that the blood, like the red cells in the plasma, just keep going directly back to the patient during the treatment. And then the leukocytes are the cells that will be treated. And that can use in some type of cancer, like the cutaneous T-cell lymphoma, and then also like use in organs transplant rejection. Other indication for cytopheresis, skip that. For anyone that has an interest in extracorporeal therapy, there is the Hemodialysis Academy and the Extracorporeal Therapy Fellowship. And so conclusion of this is that, you know, extracorporeal therapy is really a life-saving therapy for a patient, because for a lot of them, there is no other option. There is no other therapy that actually working. So when they are in kidney failure, not producing urine, like if they need time to recover, there's nothing that can help them. Without extracorporeal therapy, they just don't survive. And same for like other type of disease. But the really interesting thing that really excites me about extracorporeal therapy is that there is a lot of opportunity of research and therapy that can be applied to a patient, and it can help more of them. And again, this is Callie, our first patient, and then Corina and Christine, that you all know, that are amazing nurse, like help us get the program up and running. So if you have any question, let me know.